and welcome to Voices of LH, brought to you by our This is Lakeridge Health campaign. My name is Shara Santon, and I'm the Senior Director of Strategic Communications at Lakeridge Health, and also your host for the series. Today, we're in the Sports Lounge at the beautiful Lakeridge Gardens, and we'll be interviewing two special guests, Dr. Berger and Dr. Campbell. We'll be talking about all things pregnancies and fertility. I hope you enjoy it, and don't forget to subscribe. So welcome, Dr. Berger, and welcome, Dr. Campbell. Thank you for joining us on this week's episode of the Voices of LH. And so tell us a little bit about yourself and how you ended up at Lakeridge Health. Maybe we'll start with Dr. Berger.
Hey, thanks. My journey here started after my residency when I decided to do a subspecialty fellowship in maternal fetal medicine that allowed me to combine two of my loves, the craziness of obstetrics and surgery, along with my love of internal medicine and the complexities of internal medicine. So after that fellowship that I did at Mount Sinai Hospital in Toronto, I took on a position at St. Michael's Hospital, now Unity Health, where I developed and led the maternal fetal medicine division there up until September of 2025, where I decided to make this big move eastward and make this very smart decision to come to Lakeridge Health.
Very smart decision.
I agree.
And you were also named the top doctor for Toronto in 2026. So congratulations. It is still a feat.
I didn't know that.
I know you're shy about that.
It's not the top doctor in Toronto, but this neighborhood newspaper names the top 500 doctors by specialty in Toronto, and I was one of them. I have no idea how they choose that, but it's better to be one of the top doctors than one of the worst doctors.
There
so
you
I'm happy
go.
to be in that list.
But still, nonetheless, it's a great feat. So congratulations.
Thank you.
From me and the team. All right. So Dr. Campbell, please tell me a little bit about your role here at Lakeridge Health. And I know you're also at Dream Fertility.
That's right.
Let us know
Yeah.
how you came here.
So I did my training in Toronto. I graduated in 2014 from my obstetrics and gynecology residency. And not long after that, I started actually at Lakeridge in a position as a OB-GYN, initially first as a locum, which is often how we physicians get started in our job position, but that was in early 2015. And really I've been here ever since. So yeah, I started my practice with the Oshawa Clinic, and then Dream Fertility opened in 2021. So I split my time between doing fertility care, obstetrical care in my office, and then specific shifts at Lakeridge covering our obstetrical unit and the obstetrical and gynecology department, which is a really lovely mix.
Great. So I don't know if any of you guys know this, but your Dream Fertility is also the only female-led fertility clinic in Durham Region. Or please correct me if I'm wrong.
That's correct. Yeah,
Okay,
that's correct.
there you go.
Yeah,
More ones.
Yes.
All right. So you spend most of your time at the Lakeridge Health Oshawa Hospital, correct?
Correct. So Lakeridge Health Oshawa is my primary site. Yeah.
What does your day-to-day look like?
So days when I'm at Lakeridge, it depends a little bit. Many days I'm there covering our labor and delivery unit. So that's a 12-hour shift. That can be the day or the night. And one thing I really love about it is you just really don't know what you're going to get when you walk in. And sometimes things start very calm and peaceful. And next thing you know, ambulances are coming in or who knows what. So one part I really love actually about working on the unit is that whatever kind of comes across our path in terms of patient care needs on the unit, it's always been for me in the 10 plus years that I've been at Lakeridge, such a collaborative and almost, there's a feel of almost family in that over those years that I've worked there, I've gotten to know our team of nursing staff and other support staff, including our admin staff and all the other staff that support our unit. And feels lovely to show up for a shift. And it also feels great when we work together to overcome a difficult situation or make sure we can rally quickly to provide urgent care that is sometimes needed for a patient. And many of the team I've known for the 10 plus years I've been here, and we have a lot of fortunately new members as well, which is great that we're growing and expanding. But yeah, for me, that really speaks to what the sentiment I get when I'm sort of at Lakeridge or thinking about Lakeridge, is that sense of coming together and working as a team and feeling like it's sort of a coming home in a way.
Yeah. So is it safe to say that both of you are in the field, or your focus is on high risk pregnancy loss? And if not, please do unpack that a little bit. Like, what is exactly your specialty?
Sure. So I'm a general OB-GYN. That was my initial training. And when I first started my practice here in Durham Region, I was doing more of a general practice. Over time, that evolved in that there was not a lot of providers providing fertility care close to home. And so I started to expand into doing more fertility care. I underwent then a College of Physicians and Surgeons of Ontario change of scope of practice to do some additional training, working closely with some expert physicians who had done fellowship training in reproductive endocrinology and infertility, which is kind of the additional couple of years of specialty training that people do to be credentialed to sort of provide that fertility care. So since I shifted towards that, I would say my practice has really then developed more into somewhat of a high risk obstetrics practice, because typically the patients I follow obstetrically are patients who have been with me either from a fertility standpoint because they were struggling with fertility, or from a recurrent pregnancy loss standpoint. And so often there's various factors that then contribute to them being high risk, but I'm not formally a maternal fetal medicine specialist or high risk specialist like Howard, which is partly why we so very much welcomed him, because I definitely could say that in the 10 years I've been here, the acuity and the sort of like level of risk that we see amongst our patients, I think has increased. So having Howard here is a hugely valuable resource.
Well, an example, just today, by chance, I spent the morning doing a virtual consult on a very complex patient of Melanie's who has multiple medical concerns and has also a difficult journey in the fertility arena. So it's where our specialties intersect, and it's lucky that we both have each other here, to each one being able to solve an aspect of this patient's problem.
Got it. So I have here that you did a fellowship in maternal fetal medicine, and you also have done a whole lot of research, which I don't even have the vocabulary for. So can you walk us through what your specialty is and how that is being applied or translated here at Lakeridge Health, especially as you're in your new role as the chief of the... Yes.
It's a bit of a different... it was a bit of a sidestep for me, and it is a change a little bit in what I've been doing all my life. The maternal fetal medicine aspect, for those that don't know, really translates into what is colloquially called as a high-risk pregnancy. And high-risk pregnancy is a very general term, and it can be from something minor, like a relatively minor finding in the fetus and the baby during the pregnancy that requires another set of eyes, to moms who have complex heart disease, lung disease, previous brain surgeries, and things that coincide with them also, seeking a reproductive journey and being pregnant. And so this specialty really combines all of that. We'll see moms and parents who have either these complex maternal problems, or something unfortunately is found throughout the pregnancy that requires some specialized care or additional diagnostics. So we do a lot of ultrasound. We do advanced ultrasound during the pregnancy to identify fetal concerns and to help monitor fetuses that need that extra monitoring so that we can ensure the best possible outcome. And in the same clinic, we'll also see that baby that's fine, but the mom who has kidney disease or has other chronic illnesses that require a very multidisciplinary type of approach. And it's not just me. We always have to bring in all of the other relevant subspecialists at Lakeridge. Now, you said correctly, I was very academic in my previous life. That was, I'm a full professor at the University of Toronto. I have done lots of research. My primary areas of research did relate to diabetes in pregnancy. But and right now we're rewriting the guidelines for Canada on diabetes in pregnancy. They should be coming out in a couple months. So that was a very strong focus, but I did that for about 20 years, and I enjoyed the educational aspects. I helped train lots of residents and fellows, and then coming here was very attractive to me after a little bit of coaxing, because I'm never really wanted to do the managerial part of this. I focused mostly on the clinical part, but I love your chief of staff, or our chief of staff, Randy Wax, who I knew from Sinai, and then the challenge and the need in the Durham region really brought me to this. One of my interests when I was at St. Mike's was expanding and bringing maternal fetal medicine or high-risk pregnancy care to the periphery and to areas that did not have it. And we did that in several areas around Toronto and as far north as Barrie. And when you look at Durham Region, there is exactly 0 maternal fetal medicine specialists, but now there's 1.
Up until now.
Right, exactly, up until September. And that's really important in my opinion. And I do have that drive it gives me a lot of satisfaction, and I think it provides an important service, which we'll probably talk about.
Amazing. So up until now, people in Durham Region were either going more east or more west to get high-risk pregnancy support, or?
Yeah, I'll tell you exactly what happened. Whatever our generalist OBGYNs need to refer sometimes. They're required to. You can't, not everything can fall on their shoulders. They need that extra expertise. And when it's not available here, you have to send the patients elsewhere. Mm-hmm. And most of it's into Toronto. And we know how lovely a drive it is into Toronto to come for an 8 o'clock ultrasound at Mount Sinai Hospital or St. Mike's or Sunnybrook. And some people will do that and they'll get excellent care in the GTA, or in downtown Toronto, but some won't do it. Some can't do it. Some can't take off work. Some can't pay for parking downtown and will just not get the appropriate care that they need. Yeah. And our great OB-GYNs just struggle through that. And that's where the telephones I would get from Mel, from Suha, from all the team here that I kept in contact with, they would call, but it's not the same.
Yeah.
And that's what Durham women needed to do.
Okay, so in your role as a chief, what are some of the changes that you're hoping to see over the next 5 years within the women's and children's program, at least in particular? Well,
I mean, there are lots of goals. We have to. What's attainable is, I think that still in the Durham region, in the postal codes of the Durham region, many women are still choosing to deliver outside of our region. Some need to deliver, a minority need to deliver downtown because there are different levels of care in different hospitals, and that's appropriate. But some still deliver outside for other reasons, and I'm not sure what they are. But my goal would be to make Lakeridge Health have all the facilities and make it very attractive for all women in Durham Region to consider Lakeridge Health for their delivery journey. So that's a very a big goal, and it requires lots of changes within our system internally, and some things we can do internally, and some things we're reliant on the ministry really recognizing that the population growth in Durham Region requires some sort of infrastructure changes here, so that we can provide these services and make it attractive to come to Lakeridge Health. So I think a lot of that is happening. There's a lot of awareness, but money crunch is everywhere, and that's the case. And I think that building the high-risk clinic, which unfortunately is not fully open yet. So if we're trying to refer patients, we can't yet. But I'm just coming from a meeting now, and I'm sure that within a couple months we'll have a full-blown high-risk pregnancy clinic where our practitioners can refer and the patients can come for shared care and that extra level of consultant care that previously they would have to go to downtown Toronto for.
Oh, wow. I was thinking a couple of years, but you're saying
No, it's months.
Amazing.
No, it's definitely months, yeah.
Oh, that's exciting. Great news. So I want to talk about fertility in particular. So in your perspective in working with patients or clients who are dealing with fertility challenges, let's say, how are you seeing the patient journey evolve overall? From fertility care through pregnancy and delivery, are there new trends or anything of that sort that you're starting to see, or anything that you'd like to share?
Yeah, I mean, I think I would echo a little bit what Howard was saying earlier, and the view to kind of expand services not just to be so central to Toronto and really the biggest centers, but to be really close to home, because we know that often is the best care for patients. And I guess I would say in my experience too, that, almost every patient I see, if not definitely every patient I see, finds the process of what they're going through to be pretty stress inducing, right? Not achieving what they were hoping to achieve in terms of thinking, maybe we're going to try and get pregnant really quickly and that's not happening, or we're trying to get pregnant and we had a miscarriage and then, we've had now another miscarriage. And so, that in and of itself is already something that is really weighing on the patients who go through this. So, in creating Dream Fertility, our goal was really to have excellent care in Durham that supports the reproductive health of our growing population here. And it really is, highly in demand, I would say. So we are very fortunate to work collaboratively with Markham Fertility. So when our patients need IVF, the actual procedure of the IVF happens there, but that's just really one trip they have to make in their cycle. The majority of visits and care is all happening locally at our clinic at Dream Fertility, which is great. So I think from the fertility standpoint, our patients are fortunate that they benefit from being able to do their IVF at a center of excellence like Markham Fertility with an excellent lab and it's an overall wonderful clinic, and also still be close to home for the majority of that. And then what I find also helps a lot of patients, and I think I'm fortunate to be in a very unique role because I don't actually know of not that many people, or maybe any other people, who are both, managing patients' IVF cycles and then also doing fertility care, obstetrical care. And I think that's just a function of the fact that I ended up being in practice in Durham and it was a need, and then I was able to, change my scope to kind of include that. But to be able to kind of walk people from the starting point of a difficult journey through a process that often could include in vitro fertilization treatment, and then get to care for them through their pregnancy, and sometimes be lucky enough to be the person who is actually there to deliver their baby, is something I feel incredibly grateful for. And then I often hear at the kind of end of that process, when we do typically a 6-week postpartum visit once someone has delivered, how helpful it had been that those patients were able to receive care close to home, that they were able to have some continuity of care, that they had excellent, interactions with supportive staff that they got to know at our clinic. And then another thing that happens in my office is I have one of the nurses who is one of our labor and delivery nurses, who is amazing, works in my office helping me with my prenatal clinics. So I would say in the majority of cases, most of my patients who go in to labor and deliver at the hospital, if they don't happen to find me on call, they will very likely happen to find the nurse that works with me, Brianne, there. And she's actually been at Lakeridge for 22 years. I found out from her today. So that kind of continuity, I'm always hearing stories of just how lovely it was when, labor set in, and that was very, potentially stress provoking as well, and a lot of uncertainty. And then to show up at the hospital and see a familiar face like Brianne made a big, big difference. And sometimes it's not always a familiar face, but just that there was, someone along the way, whether it was part of our postpartum unit or whatever, that really, a nurse who really took an extra bit of time and addressed a concern or a need that person had. So I think there's a big value for patients when many of these things can be quite stressful, to have some continuity and some consistency and know that there's resources there that they can sort of turn to when things are not going the way that they might have hoped.
So does Dream Fertility offer IUI services as well?
Yes, okay. So we do also do IUI. So in addition to, yes, sometimes my patients might have needed IVF to conceive. Sometimes they might have needed IUI to conceive.
And what's the difference between both?
So in vitro fertilization is a process where we, at the beginning of a menstrual cycle, we're having a woman take high dose medications by injection with a view of growing many, many eggs at once. And then we retrieve the eggs from their body using a needle and ultrasound guidance. And fortunately, at Markham Fertility, they get to be asleep for that process, so it's not painful for them. Then we're fertilizing eggs with sperm in our lab. And then we wait for embryos to grow from that process, which we hope we get many of. And then once we have embryos, an embryo can be transferred fresh into a uterus or can be frozen and transferred later. And even just the process of that can be really helpful for some of our patients, because some of our patients have medical reasons, where sometimes I'm asking for Howard's help to say, like, we can't necessarily get them pregnant right away, but we could at least make the embryos. Then we have time to sort of address many things. And later we can then put an embryo in their uterus to actually get to the point of pregnancy. Insemination or IUI is a process where many times we're doing a combination of what's called controlled ovarian stimulation plus intrauterine insemination. So it's giving a much lower dose medication. Often it's an oral medication rather than injections to stimulate the ovulation process a little bit. So we might get, rather than just one egg ovulated, which would happen in a typical natural cycle, maybe 2 or maybe 3.
That means twins.
Yeah.
Or triplets.
So again, we do counsel about that risk of that, and that's where sometimes we need that.
And they give me work.
Expertise.
Yeah.
And then we monitor, again, the process of the developing follicle with ultrasound and blood work, and monitor the uterine lining with ultrasound. And at the appropriate time, the patient gets what's called a trigger shot to help time exactly when ovulation will happen. And then we time the insemination to happen at that appropriate time.
So it's less invasive than on IVF.
Exactly.
Okay.
Yes, it's less invasive. It's more affordable. It's also less successful, but it's often a place where I find a lot of my patients prefer to start, and it's much more comfortable to start. Yeah.
So are we seeing a lot more fertility challenges these days? I know I don't know if it's a rumor, if it's a truth or not. I'm a non-clinical healthcare professional.
Yeah.
But I've heard a lot of anecdotal evidence to say that, I got the COVID-19 vaccine shot, and ever since, like, my, menstrual cycle is different, or a lot of people are having infertility challenge or issues. Is that true, or is that just, false media?
Yeah, I don't think there's any truth to the COVID-19 shot causing infertility or menstrual cycle irregularities. And I think that's actually been looked at by a few studies since we had the COVID pandemic, and been shown to really not be the case. But definitely, I would say that the likelihood of infertility is rising in the population. So we know 1 in 6 couples will be diagnosed with infertility. So it's actually quite a high rate. And I suspect that that number will rise. I think a big part of that is delayed childbearing. So just we're often older when we start our families because we have many other demands, including education and career and things like that. But I think there's other things that play into it. Like, definitely we know that things like PCOS or polycystic ovarian syndrome can be really closely related to obesity. And so, seeing trends in the population where maybe people are not as active as we would like them to be, and busy lives, and not maybe eating as healthy as they could, that can often be something that with some weight gain triggers more menstrual irregularities and a push towards a diagnosis of PCOS.
Okay. Thanks for that. Thanks for the honesty.
But I did read that Durham Region has the highest birth rate of all of Ontario or Canada. So
Yes.
and maybe it's because of Melanie who's doing something right.
Well, we do have a growing population, so
Yeah.
we should look into that. Maybe it is infertility. All right. So what support services are available for pregnant people in Durham Region through Lakeridge Health or across Durham Region?
Well, as chief, I'll take
Sure.
that. So we're lucky enough to have 3 regional sites where you can deliver a baby through Lakeridge Health. The largest site is Lakeridge Health Oshawa in Oshawa, and then there's our site at Lakeridge Health Ajax Pickering, which delivers about 1,500 babies a year. Lakeridge Health Oshawa about 3,000, and then in Port Perry we have a very, very lovely birthing unit that delivers about 500 to 700 babies per year, and in each of these centers, different care providers can provide care, and it's not always the same at all of the centers. So at Port Perry, all the deliveries are managed by family medicine obstetricians that are always on call there. At Lakeridge Health Oshawa, we have midwives, family medicine obstetricians, and a large practice of obstetricians and gynecologists. At Lakeridge Health Ajax Pickering, we have a midwifery group and obstetricians and gynecologists. Family medicine does not practice there.
Okay. And for the purposes of this episode, we'll refer to women, but it could also include pregnant people?
Of course, we definitely realize that we always are used to using the term woman, but we definitely mean anyone who identifies as any gender and is seeking pregnancy.
Okay. So what about NICU?
So the neonatal care unit obviously has to exist at any site that delivers babies, but there are different levels of care. And it's usually based on the age of the delivery, the gestational age of the delivery. So at Lakeridge Health Oshawa, we can accept newborns into the NICU from 30 weeks onward, and at Ajax Pickering at a little bit later gestational age, and in the Port Perry site where they don't have the same resources, mostly term or 36-week babies and beyond. And although not always perfect, we're very good at determining who's best to deliver at which site. And if things happen, then we have a great transport system between sites, and so we have all this covered.
Okay. I'm going to probe a little bit on one of your studies, which is diabetes in pregnancy.
Yeah.
Is that what it's called formally?
Well, diabetes, I mean, that's a general, it's a general term. There's a lot of diabetes in pregnancy for many of the reasons that Melanie said. The increasing, body weight in general in the world is along with that always at all ages comes a rise in all different types of diabetes. And there's a special type of diabetes that occurs first in pregnancy, and pregnancy brings it out because it's a stress test for lots of physiological things that happen in moms. And those women will actually usually afterwards, within the next 10, 20 years, will be diagnosed with what we call type 2 diabetes, which is the very familiar type of diabetes. But all extra sugar in pregnancy in the mom's blood affects pregnancies in different ways.
So I know the publication is not out yet, but what can you tell us about diabetes, I guess, in pregnancy? What do you know today that you didn't know about that 10 years ago, let's say?
Well,
what's changed?
One of the biggest, not as much as I'd like, but so first of all, there are a lot of new medications and a lot of new ways of delivering medications. So I'm talking mainly about type 1 and type 2 diabetes. Now, type 1 is what we call the juvenile diabetes, where it starts at an earlier age. You're dependent on insulin, and that used to be a death sentence. Pregnancy in a type 1 diabetic patient was a death sentence 40, 50, 60 years ago. And that's obviously not the case anymore. And so one of the biggest changes for type 1 diabetic moms is that the use of pumps, that we bury underneath the skin and that give constant delivery. And now the biggest change is that they talk, the sensors that measure your sugar talk to the pump, and they act sort of like an artificial pancreas. So women who have type 1 diabetes really don't have a functioning pancreas, so they can't do that important activity of sensing the sugar and then responding with the insulin. But this connection between this AI brain and the sensor and the delivery system is leading to much better outcomes than in the past.
So cool.
And for type 2 diabetes, what we're going to be seeing now is I'm not giving any plugs for Ozempic, but everyone uses Ozempic, but it's the GLP-1 agonists, which are, of course, everyone is catching everyone, taking everyone by a storm, but it's a really efficient medication for type 2 diabetes in patients that are also obese, and it helps reduce the blood sugar levels and helps reduce weight, both things which are really good in ensuring a successful pregnancy and not having miscarriages, having a lower rate of miscarriages in the first trimester, and then better control throughout the pregnancy to avoid the effects of high sugars throughout the pregnancy. We don't want people continuing these medications, these GLP-1 agonists during pregnancy. There's no evidence of safety yet, but the good news is there's no evidence of harm if you got pregnant while you were on it for the reasons that your doctor prescribed. We will want you to stop it, but it'll probably, and we're looking at this, we're learning, probably you will have better outcomes because you'll be entering your pregnancy in a better, in a more controlled state. And it'll be easier for you to get pregnant. And I know Mel agrees with me on that.
So when we talk about infertility, it's always about women. And I think there is a cultural shift. People are becoming more aware that no, it takes two, right? So what, do you have any advice? And either one of you can answer this, but do you have any advice for both men and women who are trying to conceive or have healthy pregnancies?
Yeah, I mean, I think from the male standpoint, I would say I think it's becoming a little bit more widely known that if we look at sperm parameters, they are kind of getting worse as a population over time. So again, I don't know that there's been one perfect study, but there's varying studies and evidence that have shown that, like, if you look at kind of just sperm count, sperm motility, and that probably reflects to some degree our health as a society, right? So, I mean, I would say, in line with what Howard was saying, like, I have found the GLP-1 agonists to be, they're not something I prescribe. I'm not an expert in that, but we're fortunate to have many like weight loss clinics and things like that where we do have medical experts to help with those things. And so that can often be like a really helpful thing for helping bring everybody's health and physiology to a little bit better state. That often can help with improving sperm quality, improving egg quality. So I think, yeah, on my side, I would say, like, it's definitely a communal problem in a couple or relationship, if it is a couple or relationship, because sometimes I'm also dealing with someone who is just choosing to be a single parent by choice or things like that. But it's definitely, both partners that need to be involved. And I would also just say, like, my absolute favorite thing that sometimes happens when I'm seeing a couple for a consultation is the male partner, when I say, when was your last period? And the male partner pulls out their phone and says, oh, I know, it was this day. And I'm like, excellent. I just know that couple is going to have an easier time moving through all the next steps of things that may need to happen, because you can tell immediately that support is there, that they're both really invested in, what they want, what are their goals, kind of as a couple, as a family. And I don't know if Howard would add to that.
In general, the general rule for pregnancy is your outcomes are going to be better the healthier you are when you get pregnant. So if you have a chronic illness, it's really good to get everything under control and stabilized. It's okay if you have it's better if you don't have any chronic illnesses, but that we can't choose. So if you do have it, make sure that you seek out the guidance from your family physician, from an obstetrician, from a maternal fetal medicine specialist if required, to really optimize your health when you conceive, because that helps you conceive, but it also helps you have better outcomes throughout the pregnancy. In general, it is better to have babies when you're younger. Okay. Also genetically, a lot of things that we deal with are
younger. What does
I don't know. I'm not going there. I'm not going there. I'm not getting involved. But this is just a physiological fact, and I'm not saying there are many reasons to delay childbirth, and that's not a judgment issue. But biologically, we can't fight the aging of the eggs, and as eggs get older, it gets harder to get pregnant. There are more miscarriages in the first trimester, and there's a higher risk of some chromosomal abnormalities. And this, we all know, everyone who's been pregnant has gone through this discussion about Down syndrome screening, and there are other chromosomal abnormalities, and some of them are related to increased maternal age, maternal in this case. Paternal age has a little bit of an effect on some things, but not on the same things. So luckily, you're asking what has changed a lot in obstetrics and prenatal care. One of the other big changes is our ability to do genetic screening now. And for couples that are interested, they can do genetic screening before the pregnancy, and that's called carrier screening, to look for these weird and wonderful things that might exist in a family tree without anyone knowing. And so there can be counseling about that, and Lakeridge Health does have a whole genetics unit that can provide this counseling. But the other big change is that most people are not as well organized about their pregnancy. Things, life catches up on us, and suddenly we're pregnant. And so it used to be that if you wanted to know a lot about your baby from a genetic perspective, you had some blood tests that were not perfect, or you could stick a needle into your belly and take some amniotic fluid out from around the baby. And I like doing that. But when I offer that to anyone, most women look at me like I'm crazy and say, don't get any needle near me and definitely not near my baby. And that's incorrect, but I understand the fear. But nowadays, with the advances in genomics, we can, through a maternal blood test, identify with almost 100% accuracy if your baby's going to have Down syndrome or not, which is amazing. And I'm simplifying a little bit, but that's a really, really big advancement. And what's going to happen as we learn more and more how to separate the baby's DNA from the mother's DNA that's floating around in her blood, we'll be able to expand that into identifying a whole multitude of genetic disorders that previously we would never be able to identify.
And do we have any sense of timelines in terms of when we can expect?
It's like computers. Everything, it happens very fast. The advances are happening every year. I mean, and so there are ethical issues that complicate this.
Yeah.
So too much knowledge also complicates things. So I'm happy to talk about that in a whole separate discussion, because there are many nuances to this, right? Because not everything you identify genetically, you can actually predict what the outcome is going to be. And then if you have to make difficult decisions during a pregnancy, you really need better information. Mm-hmm. So that informatics is really an important part of, it's not just being able to identify certain differences in the DNA makeup of a fetus compared to the mom. You really have to understand what that means. But this is a brave new world, and this is something that maybe I'm too old to have to deal with it. Maybe whoever replaces me will be dealing with these complex issues.
Well, thank you for that insight. So what are there any advancements in terms of not technology per se, but AI in particular, that are being implemented or integrated in the services that you're offering, whether it's through Dream Fertility or even in your day-to-day? How is AI informing some of the work or decisions that you're making in your current roles?
I would say on my side, it's not yet, but there's lots of potential prospects and thoughts for where it possibly could help. But yeah, we're not there yet in practice. And I think also as these things are starting to come into play, one of the things that often is a barrier for, an idea or a concept or a technology to then roll out to actual patient care is often ethical concerns and safety concerns. And those things sometimes take longer than, the development of the ideas.
They should.
Yeah.
AI, we're not using AI enough in healthcare, and I think it's definitely going to change. Every year we talk about it, it'll be different. I think that right now applications are in streamlining some of our processes. It helps us take notes, and so a lot of units are using what we call AI scribes, where it just listens in the background and creates an amazing summary of the patient encounter, much better than any of us can do. And so that's going to be adapted into Lakeridge Health, in the clinics in Lakeridge Health very soon. I know it's being trialed right now, so that's really exciting. I think that just helps. Ultrasound and imaging is going to be very much AI driven. So AI can help already with chest X-rays, and that's nothing that I do, but it can do a basic screening of a chest X-ray and do work is just as good as a radiologist, while identifying a subset that needs an extra set of human eyes and will not miss things in those that it says are perfect. And it's a little bit harder with ultrasounds of babies, because babies are a moving target that's moving inside and jumping around, and is really a little bit dependent on who's holding that. But we're already, we have machines that I can just put the probe on, it'll tell me what organ I'm looking at in the baby. And if I press the freeze button, it'll measure it. It'll already trace it out for me without me having to do any extra buttons on it. So you still need me, you still need someone holding the probe, you still need looking at it, artificial intelligence learns. So the more you feed it, the more it'll be able to be good at things. And with regards to diagnosis, it's probably going to come into healthcare. And we want to make sure it's safe, and we're not missing things. But we also realize that in many cases it can be as effective and as accurate as the average physician. So we might be out of a job a little bit, but luckily AI is not going to be able to deliver a baby anytime soon. So they'll still need us for that.
physicians are not going to lose their job, but physicians who do not know how to use AI
I think
might.
you're right. You can't stay behind. Yeah.
Yeah. Okay, so what's one last thing you would want our viewers to hear from you when it comes to fertility or high risk pregnancy or anything overall? Do you have any piece of advice for our viewers?
I would say, I think one of the biggest things is to be your own advocate. And I think that's often needed to sometimes get the care you need and get the services you need. And one of the roles that we are asked to focus on in our training is the role of a physician as an advocate. And I have found more than I thought it would that comes into my day-to-day practice every single day. And I would just encourage patients as well to be their own advocate. And I do see that often, that I think patients are more comfortable to speak up for themselves, to like ask questions when they don't understand. I think when you're going into an encounter with a physician, it's great if you have your list of questions or the things you want to know answers to. And I know, like, from a fertility standpoint, I'm always encouraging patients to, get more information. And we may have our kind of definitions of infertility, but sometimes it can make sense to see a physician even before you necessarily started trying, to think about protecting your own fertility by freezing eggs, or even just do some basic testing, or even just to have a discussion. And sometimes it's not any tests involved, to educate yourself. Because I think one of the things that I think is very scary to me is the propagation of misinformation that we see in social media and other places. And I also find another huge part of my job is education, and just basic education to patients about basic concepts, sometimes related to the menstrual cycle, sometimes related to specific treatments or things they may have heard about online and they want to know more about. And I try to be really honest with patients to let them know that sometimes the research we just don't really know. We have one study that shows that thing might be kind of beneficial, and another study that shows it's probably not that beneficial. But I think just trying to provide that transparency and clarity for patients can be helpful. And I just see that when patients are not seeking out information from reliable sources like their trusted healthcare provider or physician, then often it can be really stressful because they're inundated with a lot of information that might not actually even be the right information. And then that's leading to other things that, can be problematic.
I recently saw a social media post where this individual, no names mentioned, was offering a one-pager on fertility or infertility to women, and they're not even a clinician. They're simply an influencer trying to promote good
If it
lifestyle.
seems too good to be true, it probably is.
Yeah. So, moral of the story: don't trust what you hear online. Talk to your docs.
And my last, I mean, I won't echo everything that Mel said, but she's obviously right. I think we just, out of all this, we talked about high risk. Remember that most pregnancies are low risk. They should be enjoyable events. We should stay healthy during the pregnancy and active, and not over-medicalize pregnancies that don't need to be over-medicalized. And we have great teams here that can provide that appropriate level of care for the majority of the low-risk pregnancies, be it our general OBGYNs, our family medicine obstetricians. That it's a whole separate group at Lakeridge Health that provides care as your family physician and as your obstetrician for the delivery, as long as it's a low-risk pregnancy. And we have our groups of midwives for people who choose to go the midwifery route, and we all work in collaboration. And when someone doesn't fit in one group, we immediately move to the other group. And when you need to medicalize the pregnancy, my goal is that Lakeridge Health will be able to offer and offer the things that person will need throughout the pregnancy journey.
Amazing. So if there's, last question now, if there is one word that you could think of that best describes your experience at Lakeridge Health so far, what would that be? And I'll give you a few seconds.
I think I would say evolution. Again, it's a little bit scary to say that it's been 10 years. It makes me feel very old that I've already been there. But in the 10 years I've been there, I've seen many changes for good that have happened. like even just one example is when I first started at Lakeridge, we didn't have a thing called a code OB, which was if there's an obstetrical emergency, we need everyone that we need, who's our anesthesia, our pediatricians, our nurses and support staff, to like essentially run to the place we need them to be so we can get a baby delivered safely. And that is something that has evolved in the time that I've been at Lakeridge and is hugely beneficial. And I think every time, unfortunately, there is a code OB, how big of a difference it makes in achieving a good outcome for that patient and that baby. And I, have just been impressed during my tenure at Lakeridge how I think there's always a constant moving evolution towards progress and improvement and improving systems and improving collaboration and things like that. So
what's
evolution
the one word?
Yeah, should it come to one word? Oh,
There
okay.
you go.
Sorry, did I not say that right at
Yeah,
the
you
beginning?
did. Yeah.
What's your one word?
I don't have anything to compare to, so my one word is when I walked into Lakeridge is friendly. It's just a friendly place, and at all levels. And I've been very much welcomed, and out of that friendliness comes collaboration, and there's a lot of professionalism that comes with that, which is just an added bonus. So that's my one word.
Amazing. Well, thank you both for joining us today. And you both actually spoke at our first 2 Women's Health Symposium, and I think a lot of our community members were able to hear from you directly. For those of you who don't know, we're actually launching our first ever Women's Health Collective, which is a safe space for families, women, men included, to join us, hear from our healthcare professionals here at Lakeridge Health directly, learn about health topics that are relevant to you in the community, connect with our healthcare professionals, and finally share your feedback. So please do join us, register at the link on the screen, and you'll hear more updates. Without further ado, thank you.
Thank you.